Thank you, Mihaela.
Our next speaker is Mihaela from the Schaar from Cambridge and the Turing Institute, and she will speak about personalized treatments, precision medicine beyond predictions.
Thank you very much, Carola. Thank you for inviting me to give a talk here. And what is interesting is that it's almost a year ago I gave a more theoretical talk about this work also at the Isaac Newton Institute. So what I plan to do today is to recap some of the background, briefly tell about the results we had 1 year ago, and then kind of refine those results and also show to you how far we have got into using this type of methods to bring them to a real application domain, and how we start to now experiment and develop some new results together with our clinical collaborators. So the focus of the talk today is kind of going beyond predictions, starting to look at treatment effects, and the previous talk was a perfect introduction for this, so it's a perfect link. I'd like to acknowledge my PhD student Ahmed Allah, who has done a lot of the work that I'm presenting here, and Dr. Jem Rashbas, with whom I'm collaborating on the practical side of what I'm going to show to you today, as well as many clinical collaborators that are involved with us. So overall, just to tell you a little bit about my research, my focus is on developing machine learning, AI, and operations research techniques with an overall goal of supporting clinical decisions and clinical discovery, both developing decision support systems for clinicians, understanding the basis of health and disease on the basis of what we have learned, as well as improving clinical pathways, which may go all the way from, let's say, prevention, screening, diagnosis, potentially treatments, etc. And finally, hopefully all of that will inform public health. And what I'd like to say is that often when I'm going to a precision medicine type talk and community, there is a lot of focus on genomic data, and that is clearly very important. But what is also important is understanding the complex clinical data we have at our disposal, and the previous talk has very well motivated that, so I don't need to go into the details of that. So the type of problems that I'm interested in solving and addressing in this area of my research are as follows. I have a particular person, Bob, who has been diagnosed with a particular disease, X, and what I'd like to understand is what treatment I should give to Bob on the basis of the characteristics that Bob has. So I'd like to move, if I can, from an average treatment effect to an individualized treatment effect, and provide a recommendation rather than a decision for the clinician on what would be the best treatment to provide to Bob. So the focus is on building recommendation systems for clinicians that provide such information, individualized treatment effects. And the problem that we are trying to solve is casted as estimating a treatment or intervention on an individual. The first thing that comes to mind when you see problems like that, you start to think about clinical trials. And clinical trials are, of course, the golden standard and will continue to be so. But a key challenge associated with them is that they look at average treatment effects. That's number one. Number two is that often they enroll patients that are not very representative, so patients that may be not having certain comorbidities, which are actually very prevalent in the population that needs to be treated, or that are young rather than elderly. So many representative patients are really missed in these clinical trials. Often they are small sample sizes, so we may be able to learn something about the average effect of the treatment, but not about the individualized treatment effect. And also there are many costs associated with this. So clinical trials are clearly very important. I'm doing quite a lot of work on using multi-arm bandits and some other ideas to kind of look at adaptive clinical trials. So this is clearly a very important area and is an area of interest for me. But today I'm going to move away from it, and I'm going to say, okay, now we have a drug that has been approved through a clinical trial. How can we use the information that we have from the observational data that follows from a clinical trial to identify treatment effects? And I'm going to motivate that with a first example from the area of cystic fibrosis, to which I have a collaboration for quite some time now, 1.5 years. And the focus here is on identifying both predictions and longitudinal trajectories of disease, but also very importantly, what type of treatments we can provide to different patients. And this is especially important for cystic fibrosis because these patients are both very sick, but also they get many, many drugs assigned to them over time. And it is challenging because the phenotypes are complex, so there are many factors affecting the patient's health as well as the response to treatments. So any type of decision support system could be valuable. And again, to go further into the details of this, the drugs that are available for care at times are very expensive. So an example comes from this particular drug called ivacaftor, which was the most important new drug of 2012 according to Forbes. And it is really the first drug to treat cause rather than symptoms. And it's a drug that has been on the market now for some time. And it costs a lot of money, $300,000 a year. But besides the cost associated with it is another problem. First, the type of morbidities that are prevalent in the population have not been often tested in the clinical trials that have been associated with it. And a little bit more than that, if a patient is put on ivacaftor, maybe that person is considered that they will do well, so delayed treatment, other types of treatment, like for instance, putting them on a lung transplant list may be postponed, which can have negative effects. So it's not only the cost associated with it, but also the delay in prescribing other treatments. And if you look at the clinical trials that have been used to approve this drug, they are quite numerous. However, most of them have only very small sample sizes, 50 patients or less. Most conclusions are based on a very specific mutation, and the patients recruited had no infections or comorbidities. And the outcome that was, the follow-up was relatively short. So what we would like to do here is to complement clinical trials by looking at machine learning to look at the observational data after a particular drug has been introduced in the market and use these real-world observations to identify treatment effects for specific classes of patients. And the advantage, of course, of machine learning is that fast, it's adaptive, we can improve our recommendations over time, as was said before, and it can be relatively fast deployed as a decision support tool. And it can accompany the decision of a clinician, and it can learn to interact with the clinician and based on their observations. So what is this problem that we are trying to solve? Is the problem of causal inference. And as very nicely motivated before, I'd like to first start by saying this is not a problem of causal discovery we are trying to solve here, as in the previous talk. That's a very important area, as mentioned, and a lot of interesting research happens there, but we are not interested to learn the causes of effects. What we are interested in instead, and this is a lot of the focus of my group, we are interested to look at the effects of causes rather than the causes of effects. And our work is kind of follows two different areas. One is more focused on the area of reinforcement learning and multi-arm bandits, in which I worked for quite a long time. And here an important subcategory is adaptive clinical trials. I'm not going to talk about that today. Instead, I'm going to follow up the talk of last year where I looked at causal effect estimation from offline observational data. So what I'm going to ask is, if I have an observational data set, can I identify the effects of a treatment on a specific individual? So the outline of the talk would be to motivate, after this first motivation is to explain briefly for the ones among you that may be less familiar with causal inference for treatment effect, why this is not a supervised learning problem, why it's more difficult, and why it's more difficult than a reinforcement learning problem where you have online feedback. And I'm going to talk briefly about the new theoretical results we have obtained since last year, but most importantly, I'd like to show to you a first demonstrator that we have on the basis of this work for the area of breast cancer. So the problem we are trying to solve, we are casting it theoretically in the framework of Neyman and Rubin. And this is the potential outcome framework where we have patient features. We have an assignment model, whether a patient was assigned a drug or not. In this initial part of the talk, when I talk about the theory, I'm going to assume just one treatment, but the reality is that we can extend this to more than one treatment. I'm going to keep it though as a binary assignment, whether a treatment has been assigned or not, just for the simplicity of the equations. And then what I observe is, if the decision was to not to treat, I'm going to observe the outcome for the patient if the decision was not to treat. And if the decision was to treat, I'm going to observe that outcome. So an important piece here is that I'm only observing the factual outcomes. I do not observe the counterfactual. I do not observe what has happened if I would have made a different decision. So what I would like actually to estimate on the basis of the features of these patients, so that there is an individualized treatment effects, or maybe more correctly called conditionally average treatment effect. So this is conditioned on the features of the patient. I'd like to estimate the expected effect of giving that particular drug. So I'd like to estimate what will be the difference in outcome if I give the drug or not. We are making two assumptions in the theoretical framework. The first one is of ignorability or no hidden confounders. That's a very strong assumption. We have follow-up work where we are looking at what happens if you do relax this assumption. But this is actually still, I would say, a quite challenging problem. And what's interesting and pretty crazy, and I'm going to talk about it briefly later, is that if you have hidden confounders, it's easier to solve this problem in a setting where we have repeated treatments and we have treatments over time and we can observe multiple things over time. Then it's easier to deconfound and deal with confounding problems than it is in the static setting. So I'm going to briefly allude to that later. But for now I'm going to make the assumption that there is no hidden confounder. Another assumption that we make is that we have common support. So there is no patient that was, or there is no features that, so type of patient for which we don't observe either a treated or untreated scenario. So what do we what we aim to do is, on the basis of the information that we have about treated and untreated patients, so you can think about these dots as being outcomes, these are outcomes of patients with various features. And you see that, for instance, these are patients that were treated, for instance, so we don't know the counterfactual for this. And these are patients that were not treated, and we do not know the counterfactual for them. So what we are trying to do is we are trying to estimate on the basis of the response surfaces the causal effects. So we are trying to estimate what would be the effect of treating this particular patient. Again, we are trying to do that from the observational data, which does not contain the counterfactual. So this is not a supervised learning problem where I am observing the labels. What I observe here is only part of the labels. So the ground truth is only the effect of the decision that I have made, the biased decision that I have made of treated or not treating patients. So for instance, in this particular case, the patient was treated, so we observe the treatment outcome, but not what would have happened if I would not have treated. So unlike in the setting where I'm in a supervised setting where I'm having a predictive model that I'm trying to learn, and the loss function that I'm trying to minimize is the error, let's say, between the real, let's say, outcome, the real label, and the estimated label. In this particular case, what I'm trying to do is I'm trying to estimate and minimize a loss function that tries to minimize the error between the true effect of that particular treatment and the estimated outcome. So I'm looking at something that I'm going to introduce a little bit later, is the precision in estimating individualized treatment effects. So how well can I estimate for this particular individual, for instance, the effect of the treatment as opposed to the reality, the truth that I don't know. And I'm going to do that on the basis of testing data that will not contain the counterfactuals. So one key challenge that occurs here, and I talked quite a lot about this last time I was here, so I'm not going to talk too much about that, is the idea of how to model interventions. How do I model this new variable, this assignment model of treatment or untreated? One way I can do it is by saying, well, I have two types of population, the treated population and the untreated population. I'm fitting two regression functions, and I learn completely disjointly. The disadvantage of doing that is that you kind of split your data in this way. So if you have relatively small, you are operating in a small data regime, that's kind of inefficient because you learn completely disjointly. Another type of research has done something different, was using W, the treatment assignment, as a feature. The disadvantage of that is that this is not really a feature, so you are constraining the type of representations that you can learn by doing so. And a third approach, which I presented again last year, was to really come up with flexible representations that are jointly trained. And I'm going to briefly go back and highlight that in a little bit. Another thing that it's a challenge is dealing with selection bias. So doctors are not blindly looking, they are not it's not a clinical trial, this is observational data, so clinicians have a hunch as to whether a particular type of treatment would work better on this particular individual. So the data is biased by the clinical practice and the clinical knowledge of the doctors. So hence, I'm going to need to deal with this selection bias, often also referred to as covariate shift, and the training distribution often may be really different than the testing distribution. So I need to be able to deal with that as well. There is a lot of prior work. The work comes from a diverse set of environments and researchers. Initial work in this area came mainly from statistics, applied statistics. Then quite a lot of work in econometrics, in machine learning, in statistics and biostatistics, and then more even older work, again from statistics, and more recently in machine learning. So a variety of domains have looked at this area, and the reason they have looked at this is not so much for medicine, but this is also a very important problem for advertisement. So there is an important problem in social sciences as well, where I'd like to estimate counterfactuals. The challenge, though, was that there was really no theory. All of these methods that were developed in the past were proposing a method and arguing for it without the absence of a theory. So what we have done last year, we presented the first theory that tries to provide some more principled approach to look at this problem of causal inference for treatment effects. Since then, we went one step further with this theory, and I'm going to present to you some new algorithms and then their implementation. So what we have done last year was to really try to ask more information theoretic questions and try to understand how can we really define formally this problem of causal inference and what are theoretical limits if, for instance, the sample size would go to infinity. So this was the first formalization and set of results. Since then, we are looking not only at the high sample regime, but also the low sample regime, and I'm going to show you some results for that. And then, inspired by this, we will talk about practical algorithms. And like often we do in information theory, we are going to ask a question as for what class of algorithm there is hope that I can achieve this bound. So the way we looked at this problem was in the context of information theory. So the loss function that we have is defined actually in the work of Jennifer Hill, and it is the precision in estimating the heterogeneous effects of a treatment. So this is the truth, if you like, this is the estimated value, and what I'd like to do is I'd like to minimize this loss function. Note that this is a loss function, so I'm going to try to minimize this loss. So what I'm after is doing minimax estimation. So what I have is I'm going to find the minimum treatment that is going to minimize this. I'm going to find a treatment that minimizes this loss, But since this is a lost function, if you like, this is the best estimate. So I'm going to try to estimate what treatment will maximize the effect, the potential outcome. Yeah? And I'm going to try to do that by maximizing, which again is maximization of a loss, by selecting response surfaces, and I'm going to review briefly the theory of last time, but this is what is going to come out of this is that I have two surfaces that I need to fit simultaneously on the basis of the data. The regression model for the untreated and for treated. So I'm going to try to solve this estimation problem by looking at these two surfaces. And in effect, what I'm doing, I'm trying to identify them, how to estimate these two surfaces to minimize the loss. What we have shown last year, and I am briefly reviewing here, is that this minimized loss will depend on two variables. One is the complexity of the two surfaces as defined by the smoothness of these two surfaces. So how smooth the response surface is for the treated versus untreated. And we are quantifying that by looking at Holder continuity, or if you like, in a simpler scenario, Lipschitz continuity. So I have the smoothness of the response surfaces will be one important driver of how well we can solve this problem. The other one is that of sparsity, and that is somewhat related to the previous talk, but not exactly, which is how many features of the patient that I have access to are going to impact the outcome. So that's related to the sparsity of the two response surfaces. And what we showed last year was that you can have a bound on these minimized loss that is driven by these two quantities for the treated and the untreated and treated surfaces, which are controlling the learning rate. So the learning rate, how fast I can learn asymptotically, is driven by the most complex of the two surfaces, where complexity is defined based on the smoothness and the sparsity of the two functions. And one thing that we talked about last year that I want to review here is that selection bias was not mattering, and that was unsurprising because if I look at asymptotic regime, I have very many samples and many patients, then suddenly I no longer care about selection bias. All I care is about the smoothness and sparsity of these two surfaces. However, in many settings, I don't have very many patients for many of these complex diseases, at least not initially. So how really to deal with that problem practically? So in a more recent work that followed that work, what we show is that yes, if you care about the large sample regime, everything will be driven by the exponent of as shown in here, which is really the learning rate and the high sample regime. And this constant factor that precedes it will not matter. However, in the low sample regime, this constant factor, which is nothing else than the Rayleigh divergence, starts to play a role. And so hence selection bias starts to play a role. So what we are showing in the theorem is that if you are now further away from the high sample regime, so if I'm plotting here on a log-log scale, as the number of sample increases, the minimax loss, what we see is that yes, as the number of samples increases, I mean the large sample regime, the complexity of the most dominant surface is the one that drives the learning rate. But in the low sample regime, I do care about bias. Selection bias matters. So if I have algorithms that completely ignore that, like the original algorithms that we have developed, they would do very well if I have many samples, but quite poorly if I'm operating in the low sample regime. So what I need is I need to consider both these two factors when developing algorithms. So we want models that do well for both the small and the large sample regime. In the large sample regime, the regression model needs to be chosen such that I can select hyperparameters that will deal with the smoothness of the surfaces and the sparsity. But in the small sample regime, I need to handle in a smart way selection bias and effectively use the limited samples I have to learn in the presence of this bias. So one way to go about that is to use a multitask Gaussian process. This is not the only way, but this is one possible way. And we adapted actually some of our older work to really deal with this problem. So what we have is actually we have the vector value reproducible kernel Hilbert space that is actually going to really put priors on these two GP surfaces. And what we are going to try to do is we are going to compute posteriors, given the data posteriors for the potential outcome distribution, and have a Bayesian framework to update that. And the advantage of that is that we are also having associated with our estimation uncertainty measures. So when we are issuing a recommendation, we also can issue how confident or not confident we are in that particular estimation. Again, what we are able to show then is that in the large sample regime, this type of algorithm is able to achieve the minimax bound. And the matching condition that we need to have is such that we are selecting surfaces that are sufficiently matching the most complex of the two surfaces, while really caring a lot about what happens in the low sample regime, trying to minimize selection bias. You can do this type of trade-off also using other methods, like for instance, multitask neural networks. So you are not stuck to using necessarily GPs, which may be less flexible. And you can even use generative adversarial networks, which are providing their own advantages. So you can deal with, let's say, with this lack of counterfactuals as a missing data imputation problem with bias, and you can use generative adversarial networks to deal with that as well. Now, I'd like to kind of jump directly to the experiments, because this is the biggest piece that we have achieved in the last 1 year to really bring that beyond just algorithm and theory to implementation. So first, just briefly to review the results. Usually, we don't have counterfactuals. So often when we are presenting this work to a conference or to our peers, we are using data sets as this one. This is the HDP data set. It's a synthetic data set or semi-synthetic data set. The way it's created is taking the clinical trials, creating counterfactuals, and then introducing bias and doing many experiments on it. This is one particular data set. In our papers now, we have like 50, 60 type of data sets. But on the well-known HDP work, we have tried these different methods, and our current method is quite a lot better than the existing other methods that have been proposed. So hence, the theoretical insights we have about dealing with both selection bias and large sample regime are helping to reduce this error. So again, what you see here is the lower the better, because it's error that we are trying to minimize. If I take this now to a real data set like ivacaftor, what type of effects I can estimate? What you can see here are two results, which of course will need to be validated and looked at. One which says that if the person has no infection, then there is an advantage to giving ivacaftor. On the other hand, if the patient does have infections, this improvement seems not to be there. The situation is even worse in the setting of patients having comorbidities. So if the patient has diabetes-induced, cystic fibrosis-induced diabetes, then it seems on the basis of the estimation we have from the observational data that the patients that do not have diabetes are doing better on ivacaftor, but patients that do have diabetes are doing worse. So not even a wash, but rather worse. So these are interesting, let's say, findings that of course will need to be validated by both clinicians as well as biologists, and we are working with them on this. But this is the type of result that you can expect. Now, can you go one step further? Yes, you can start to look at treatment effects over time, where I'm no longer just giving a treatment once, but I'm giving a treatment subsequently, and I make observations subsequently. A first result in this area we have published last year in NeurIPS, and kind of the ideas that we have used there was to build on this theory for one treatment to a setting that's longitudinal. And the way we did that is by using a sequence-to-sequence architecture in which now the bias that is present in the data is adjusted through a propensity weight loss that's actually learned over time. But possibly the most interesting result in this area is a very recent result with a very new PhD student of mine, Ioana Bica, where we started to look at what happens if we have confounding factors. So what we are showing in this recent work is that if you have hidden confounders, but you have multiple treatments that are applied over time, it is this subsequent treatments that you have and the observation you have from these treatments and the treatments effect over time that enables you to deal with the confounding. And this paper is on the archive. I'm not going to talk about it. It's quite sophisticated. Instead, what I'd like to talk about is something I think is more important, is bringing this to practice. So in recent time, we have done quite a lot of work with the cancer registry in the UK and look at clinical pathway for cancer. And a particular area that we have focused on, and was mentioned actually briefly in the previous talk in a slide, was that of triple-negative breast cancer, which is a very complex disease to treat, and there is no agreement between clinicians of what to do. So it's an especially good area to try to see if we can support these decisions for observational data. So what we looked at is triple-negative cancers diagnosed within these 3 years. The probability, and we looked at as outcome what is the probability of relapse. Even defining relapse is a controversial and complicated issue, but we used collaborations with Stephen Samus to define that. And then we have had a whole set of exclusion criteria, and we are left with 5,000 patients in the data set, for which we know diagnosis data, surgery type, all patients had surgery, comorbidities, and pathology reports. And what we would like to estimate is the effect of different types of interventions post-surgery, no treatment, radiotherapy, chemotherapy, or radiotherapy plus chemotherapy. And again, what we look at is estimate relapse within a year and associated confidence intervals. And what I'd like to do is something that may be somewhat courageous. I'd like to just briefly show you the demo and then I'm finishing. So we'll take a patient, sorry. I'm going to take a sample report. We do some very simple natural language processing, which now populates the pathology report. I'm going to put some information maybe about this woman, the tumor size. I'm looking at HER positive and negative. So they are both HER negative and ER status is negative. Let's say stage 2, and I have a certain number of nodes involved, and the woman was, let's say, detected by no screening. And then some time passes, and what you see is that, for instance, for this particular treatment, chemotherapy plus radiotherapy, the estimated probability of recurrence within a year is 14%. We now have also confidence estimates. We will put them there. And also we know what patients that are having similar characteristics received. We also have somewhere down, I'm not going to go through the entire demo, but we have the most similar patients. So these are the most similar free patients. But what's more interesting is we can do counterfactuals. So we can look at what happens if, for instance, I do only radiotherapy. Then you see that the probability of recurrence within a year has changed, has increased. So I can take this particular patient and go through these different types of probabilities of recurrence. I can hence compare different things. I could do something else. I could say what happens if there is no treatment. And then what happens is the probability goes up and down. And then I can try to debug that by just looking at what happens to similar patients. Again, this is an area where there is a lot of controversy as to what exactly to do. So this is an area that we need to, of course, debug very carefully. And if this would be to be a real decision support tool, we will need to go through an entire set of clinical trials and debugging this. But it's the first step in trying to go in that direction. And this is kind of bringing me to the very end of this presentation. This is one of the areas that we are working on. It's, I think, one of the most complex of the areas we are working on, but at the same time more exciting than just doing predictions. So we are trying to really look at how we can support decisions of clinicians and how can integrate this type of methodology in clinical practice. Thank you very much.
Thank you very much. Questions?
That was fascinating, thank you. I'm wondering if you can extend the theory to when you have different treatments over time and you want the effect of the first and then the second one.
Yes.
The outcome is no longer.
Yes, yes. So we have done so already. There are two papers that you know what's happening? So this is a first paper that we have tried to do so. So what we are looking at here is different treatments that are given over time, and we observe outcomes over time. The challenge is having high quality data to validate this. We are hoping to find collaborators to work on this. The way this particular model was validated is by taking a model that was published by a group of researchers in breast cancer in Nature and try to implement this pharmacogenetic model. And agnostically to that, we have tried to learn what happens over time. So this is a paper, if you like, that's methodologically showing that this can be done. We didn't take it to data, partially because we didn't have a collaborator who has access and interest in this particular problem yet, but I hope we can take it for cancer. Another example that I think is related to it is this more recent advance where we went one step further and we said what happens over time in the case you have hidden confounders. Because even more so, there may be that's not only a one-time gathering of information, but possibly information is to be collected over time and maybe there are confounders. And what's interesting is that if there are multiple treatments, it seems that it's even better for us to disambiguate between these different treatments. So we have methods that for sure can be improved. I think this is an area where we are just at the beginning, but it's an exciting area and I think the methods are ready to at least try to start evaluate them.
Other questions?
Can you give us a brief intuition about why, when you have this setup, the confounders, you can actually discriminate? I mean, you alluded to it, but what is the intuition behind it?
So the intuition is that now you can really observe different, through the factor models that are underlying the relationship across time, because there are different graphs that are evolving, you are able to make inferences about other graphs that you may not have seen, and about variables that you may not have seen.
You don't assume anything about, independence?
Oh, we do. We do make assumptions. It's not assumption free. No free lunch yet.
No,
yeah. So we make quite some assumptions about the graph still. These assumptions are often made in the theoretical literature, but whether they fit the reality, I'm going to put my head in the ground. Yeah.
So in these examples, it looks like you're sure of the disease that you have when planning the treatment plan. I wondered what the extension would be to when you don't actually know if you have the disease or not.
But you are saying, but then I may not want to treat, no? So then we are back to the setting that you were discussing more, which is about risk and risk prediction and competing risks. So if I don't know, if I'm still pre-diagnosis, let's say, often I'm interested in, is there a particular risk for this disease to occur, which may be informative for diagnosis and differential diagnosis. And yes, we have done a lot of work in the area of risks, competing risk over time. As a matter of fact, this demo that I showed to you is fully fledged for looking at longitudinal trajectories of disease. So what we are looking at is, it could be disease, but it could be also risk. So how the risk of a patient may change over time as different measurements are taken, and how the value of information changes over time on the basis of different types of observations. And actually that work, which is just predictions and longitudinal prediction, is a lot more advanced, and there we have really, I would say, high quality algorithms that are able to learn and are able to learn over time and identify what is the value of information over time to make these predictions. Yeah.
I'm wondering how much accuracy can you achieve with this work?
Okay, so accuracy at two levels, yeah, as I mentioned. So what we are trying to do here is estimate how accurately we can estimate the treatment outcomes. So we'll use this precision in estimating heterogeneous or individualized treatment effects, which is the metric we are using. So given the features of the patient, how well can I estimate the effect of giving one treatment or another treatment or a combination of treatments? As you have seen in the demo, we don't make the assumption of just one treatment. Actually, we can have multiple treatments and combinatorially many treatments. So it really depends on the setting. As you see, for instance, in the PEHE estimation, we are actually very good at estimating that. But that's, of course, a it's a semi-synthetic data with 1,000 plus patients. So if you have 1,000 plus patients that you have in your observational data, or like in the breast cancer data, or even the cystic fibrosis case, we have 1,000 plus patients, then I think the errors are actually quite low. If you have less than that, it really depends, and it depends on the bias of the data, how biased the data is. Do you really have overlap? Do you have really patients that you can observe something about what would have happened? Is there a population sufficiently distributed among treated and untreated, or the different types of treatments? So it very much depends also on how biased the data is, how much is the overlap. What I would say is that if you have quite a lot of patients, 1,000 plus, then these results tend up to be a lot better. Also, I want to say that this is a very important area where it's extremely important to have confidence estimates. And this is something that most mathematicians and statisticians are very aware of, and their methods do have that. But a lot of the work in machine learning, which is more my community, in the past has ignored that. So it issues predictions without any confidence. And what we observe is at times there is no confidence in this prediction. And since in this case you have a causal inference problem rather than a prediction problem, you want for sure to have some confidence in the estimates. So the type of methods that we have worked on provide this confidence. This confidence may be very good or very bad. So then you can decide on the basis of the confidence that you have whether to follow that prediction.
When you say very good, you mean 70% accuracy or 90%?
So as I was showing to you, for instance, so for instance in here what we have is a loss or an error, and this error is actually what we are estimating. You see, the trouble is it really depends on what you want to consider as being your metric of performance. Is the probability of wrongly assigning the drug? Is the probability of because you see, you'd like also to know, are you going to look at relapse at 1 year, if you look at cancer? So it kind of, in different papers we look at different metrics of performance. But if you want to look at what more theoretical results, here is just an error metric, and this error metric is quite close to, let's say 0.5. So that's very, very low, and if you want to have a benchmark to fill these numbers, how well this number does, you can look at, I don't have here propensity score matching, but the propensity score matching, which would be based on the average treatment effects, would be around 5. So that tells you, gives you a feel that all these methods, whether they are better or worse, are doing a lot better than an average treatment effect would do. Sorry.
audience, can we postpone all the additional questions to the coffee break because we are short on time? But this was really, really fascinating.
Thank you
very
so
much.
much.
Mihaela.